بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، وأسعد الله مساءكم بكل خير. بداية نقدم كل الشكر والعرفان لوزارة الصحة، وعلى رأسهم سعادة الدكتورة جليلة السيد جواد لدعمهم ورعايتهم الكريمة للمؤتمر الدولي حول الذكاء الاصطناعي في الرعاية الصحية، والذي تنظمه المجموعة العالمية للذكاء الاصطناعي بالتعاون مع GEC ميديا. إن رعاية سعادتكم لهذا المؤتمر يعكس حرص واهتمام سعادتكم بدعم مختلف المبادرات الهادفة إلى تعزيز الرعاية الصحية، والتي يسهم في تحقيق المزيد من المنجزات لمملكة البحرين على مختلف الأصعدة. مؤخراً شهدت الرعاية الصحية تطوراً ملحوظاً إلى جانب تطور الأنظمة الذكية والحلول الرقمية، ولطالما كانت مملكة البحرين من الدول المبادرة بتبني واعتماد أنظمة ذكية وأساليب مبتكرة وحلول استراتيجية في جميع المجالات. وقد حان الوقت إلى استهداف هذه الأنظمة والاستراتيجيات لتكون جزءاً لا يتجزأ من منشآتنا الصحية. فقد فتح الذكاء الاصطناعي الفرص لتطوير الخدمات الصحية في العالم أجمع، ولعبت جائحة كوفيد-19 دورا رئيسيا في عمل طفرة تكنولوجية في هذا المجال. ولم يقتصر الأمر على تحليل البيانات الطبية الهائلة فقط، إنما تعدى ذلك إلى الخروج باستنتاجات وتشخيصات دقيقة. سيتضمن المؤتمر عروضاً تقديمية وحلقة نقاشية بمشاركة عدد من الأطباء الخبراء والباحثين، وسنختتم لقاءنا بحلقة نقاشية تتبعها فقرة الأسئلة التي سيجيب عنها الأخوة المتحدثين. يسعدني أن أدعو الدكتور جاسم حاجي رئيس المجموعة العالمية للذكاء الاصطناعي لإلقاء كلمته، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. صدق الله العظيم. Good day, ladies and gentlemen. Welcome to the first Bahrain's AI in Healthcare virtual conference. This is a continuation of several AI conferences in the verticals we have conducted in the past 1 year, virtual and physical conferences with AI in sports, AI in higher education, AI and judiciary with the GCC Council at Dubai Expo 2020, AI and data with Her Excellency, the Speaker of the Parliament. We also thank His Highness Sheikh Khalid Hamadan Khalifa for his patronage to AI in sports. Her Excellency Sheikh Rana bint Hayy Al Khalifa for her patronage on AI in higher education, and Her Excellency Fawzia bint Abdullah Zainal, Speaker of the Parliament, and the GCC and the Secretary General for AI and Judiciary, and many other dignitaries. We also today like to thank Her Excellency Dr. Jalila bin Said Jawad, Minister of Health, for her patronage and support of these initiatives. I would like to start with also thanking the speakers who are joining from the GCC councils. Of course, our colleagues from Bahrain, but also from Kingdom of Saudi Arabia and from United Arab Emirates, various universities, hospitals, institutes. We have been long speaking in international group of artificial intelligence, which is the fastest growing AI community in the world, with over 500 members, around 30 countries, representing this community on the latest on the artificial intelligence in the verticals and how it's evolving and changing the world. Healthcare has been paramount for all of us. And we believe that during the pandemic, this has not only caused a lot of disruptions to the business, but on the other side, to AI and the digital transformation has been, cautiously said, a blessing to fast track it and expedite it. It has helped in the robotic surgeries, in discovery of the vaccines, and radiology, and many other areas which our colleagues today will shed lights on. We are all eagerly waiting for their presentations, and I will not take that further from your precious times, and I'll give the floor back to our colleagues, MC Mrs. Dalal, to introduce to others, and we shall catch up again later. Thanking you again for your attendance and looking forward to also see you in the future.
نشكر الدكتور جاسم حاجي على الكلمة والتعاون المستمر في تنظيم مختلف البرامج الهادفة إلى ربط التكنولوجيا الحديثة بالممارسات العملية في مختلف المجالات. يشرفنا دعوة الدكتور مصطفى قربان الرئيس التنفيذي للمعلومات بمستشفى الملك فهد الطبي العسكري بالمملكة العربية السعودية الشقيقة لتقديم عرضه، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Haji, for invitation. Thank you, Dalal, for introduction. I'd like to speak a little bit about the potential of artificial intelligence in healthcare, why we need the artificial intelligence in healthcare today, and why it becomes so important to have it, especially after the pandemic. Artificial intelligence, what it's supposed to do, it's supposed to simplifies the life of the patients in the first place, doctors, potential hospital administration, and to perform the manual task typically done by humans faster and by machine or by software in fraction of the cost. And this opens the area of healthcare for many opportunities, in particular for the diagnostics, for other healthcare issues that related either to the hospital or the healthcare domain in general. And this has become possible now because, as all probably you know, the data before it was all scattered. Data is not unified. It was not electronic. Many of the electronic files were kept in paper format. And now, after it being digitized, it become possible to use the AI to provide a better healthcare. Now, we would like to ask ourselves, okay, if the AI is opportunity and there is a big opportunity in the future, where are we going to utilize the AI? The answer of this question is, first of all, we need to identify what is the patient requires. Patient or our customers in the hospital expect most of the time to be treated like a human, not like a number. They expect an immediate responsive action to save lives, to provide better diagnostics. And most important is to be a consistent services. In detail, we want, as a provider of healthcare, to show the empathy. Patients want care inside the hospital and outside the hospital. It should provide the continuous care, and should the service to be either remotely or on-site, free of infections. Probably, if you know, as you know, patients, when they visit the hospital, they get infections, they get many diseases from the healthcare environment. Easier access to medical services, appointment, admission, follow-ups, easier access to medication and lab tests, continuous care, as I said, whether within the hospital or outside the hospital, and at the most is to live a healthy life without medical problems. This is ultimate things that we are looking for. Now, the application of AI in healthcare has countless options. It could be used to discover links between genetic codes, could be used could be used in the robotic surgery. It could maximize the hospital efficiency, as well as providing a patient safety when we provide the healthcare remotely to our patients. We will try to provide the maximum safety to them. And we are looking at the end to provide either to reduce the cost or to provide the service with the reasonable cost. The medical innovations either in medical devices or in other type of forms allow us and give us a spectrum of clinical decision support system, as well as open the doors for clinical pathway and order set entry. Probably one of the very good examples today is being used is a diabetic registry, as well as high blood pressure registry that is being used in the Kingdom of Saudi Arabia. And I'm sure in near future that will be linked for other registries in the JCC. This will allow the owners or the authorities of healthcare to control and provide better healthcare, especially if we know that the most the effective disease that in the region is the diabetic patients in the GCC countries. The number is increasing. Also, we provide remote monitoring through the smart tags and sensors, which will allow patient or healthcare industry to collect the data remotely. Telemedicine was an option for a very long time. Now it's become very popular and it's being used. We in our hospital, we are doing the telemedicine, and we have an initiative of providing a telemedicine for 3 hospitals in ICU. This is something very innovative and something new that is not being deployed widely, the ICU telemedicine. Robotic surgery, this is also something that is giving a very high promises of providing the robotic surgery by the experts to the rural area or the area that they doesn't have enough physicians. When the AI and deep learning is being used, we are really appreciative of many medical devices that allow us to share the data. Deep learning and medical tools streamline of radiology diagnosis. Also, it's analyzed the algorithm of unstructured media or medical data, which we collect from different medical devices such as blood test, EKG, and others. As you see, this data, whether it's in text format or whether it's an audio format, is being converted and it's being utilized to provide better healthcare.
نشكر الدكتور مصطفى قربان على هذا العرض الشيق، ويشرفنا دعوة الدكتور محمد الريس المدير الطبي بشركة سيرنر الشرق الأوسط وأفريقيا بدولة الإمارات العربية الشقيقة.
السلام عليكم ورحمة الله جميعا. أخوكم دكتور محمد الريس، المدير الطبي بشركة أوراكل سيرنر، مدير الطبي للشرق الأوسط وأفريقيا. أنا عايش بالإمارات بس originally من البحرين, and it's an absolute pleasure to join you and my fellow colleagues and to discuss AI in healthcare, because it's definitely the now and the future. Digitizing our healthcare industry and healthcare records has been just the first step. Bahrain has made a huge investment in the digitization of hospitals, governmental hospitals, even private hospitals are now digitized in the country, and AI takes us to the next step. Today, I will focus on the role of the health information system in general, coming from a vendor or an HIS provider perspective, to tell you how it really begins and ends with the health information system. Before we go into any details, just a quick overview of the company that I represent. Cerner is the global leader of HIS and EHRs across the entire world. We are in more than 70 countries. We have more than 26,000 facilities running our system across the world. And recently we've been acquired by Oracle, the US technology giant, which opens up even more possibilities to integrate AI into the health information system and the electronic health record. Today, I will speak to you in three sections, really. The first section being, where does it really begin? It all begins with data, and we'll talk about data a little bit and the importance of data, especially that I believe Bahrain has been on a system, on an HIS system, at least the majority of hospitals, since 2010 or 2011. So we have more than a decade of data. How can we use that? The data that's coming from the HIS, how can we use it to drive artificial intelligence into the care that we are providing to our patients in the Kingdom of Bahrain? The next section, I will be sharing with you how that data turns really into intelligence and decision making for organizations, for clinicians, for even for patients and revenue cycle managers, especially again that Bahrain is embarking on privatization of the healthcare industry and introducing the national health insurance program. And I will end up with how we are currently using AI and reducing the cognitive workload of clinicians while they are using the health information system at any facility, at any organization. Starting with data and artificial intelligence and the very close link in there between these two. Because at the end of the day, artificial intelligence is built on data and big data. Right now, as I have just mentioned, most healthcare organizations, not just in Bahrain, but all over the world, are sitting on petabytes, on top of petabytes of data that can be really acquired, analyzed, interpreted, and turned into artificial intelligence models, artificial intelligence algorithms that will, at the end of the day, drive decisions. And there needs to be that closed feedback loop and a closed cycle where we start from data within the clinical system, the HIS, and close it with implementing whatever models we have that we created through artificial intelligence or through particularly machine learning and deep learning into the workflow within the HIS system. And without closing that loop from data to decisions within the HIS, really the benefits are limited when it comes to AI. AI will be sitting outside of the normal workflow, the normal environment for the decision makers in the organization, whether they are the executives of the organization, whether they are the clinicians that are treating patients on a daily basis. Without having them as part of the ecosystem of the HIS, we miss a lot of benefits by not doing that. From data, we talk a little bit about analytics, and this kind of ladder of analytics maturity or analytics advancement makes a lot of sense in this context of AI. We have always worked, even before the era of digitization, we worked with reports, right? Any system or even manual systems, we were able to get reports that tell us what's happening right now, which are descriptive data, descriptive analysis. And in certain cases, whether digitized or on paper and manual, we were able to tell based on data why what is happening is actually happening. So diagnostic in nature. It has always been a challenge to go into the realms of predicting and prescribing what needs to be done. And this is where AI has come in to really help us make better sense of our data, help us predict what's going to happen, and even further, machine learning algorithms now, they are too advanced that they can tell us what we need to do as a human beings based on the data and the analysis that's done behind the scene. Moving from the first half of this diagram to the second half is really the role of AI. And AI, as you know, is no longer just a buzzword. AI is reality. AI is maturing at an unprecedented pace, and AI is really getting into every single industry in the world. We speak a lot about AI, artificial intelligence. We hear a lot about machine learning, and you hear a lot about deep learning. They're all within the realm of AI, and machine learning is just one of those techniques within AI that we've started really using and getting experienced with at Cerner and within the healthcare industry in general. Following this introduction, let's go a little bit into how we utilize all of this to make better decisions for our patients, to make better decisions for our healthcare organizations. And that's particularly transforming the healthcare data that's particularly the clinical healthcare data that's coming from the health information system, how to turn those into healthcare intelligence to support better decision-making on an organizational and on individual level. For us to be able to do that, there are four main and very important enablers or factors that help any organization move across that maturity model. Namely, first, we need to look at the people. Do we have the right people? Do we have the right people that have the right responsibilities, capabilities, capacity to be able to understand data? Do we have the right data scientists? Do we have the right analysts? That's what we do with our clients here in the region as Oracle Cerner. And the ultimate aim is really to empower users to use the information in real time to support their decision through the artificial intelligence models that we embed into their workflows. Next comes process and governance. Without a proper data governance, without proper data stewardship and ownership within your organizations and the right process to govern privacy and security, you won't be able to achieve that kind of maturity that will take you really from having the foundation of an HIS, which is a tool that collects data, a repository of data, to a tool that's gonna help shape the quality of care that you are providing. Without that governance, it's really very, very challenging and difficult. That governance is definitely gonna take us to the level of improving our data quality. At the end of the day, we always use this phrase in health information technology and every information technology domain, which is garbage in, garbage out. The quality of data that we have in our systems and our repositories is not of high quality, is not accurate, it's not credible, and we have faith in it and trust it, then any artificial intelligence machine learning model that we build is going to be doubted as well. So that's a very important factor. And finally, the technology. Really, the technology comes last. Having the right HIS vendor, having the right system and foundations and infrastructure technologically will support and will enable the other factors that you can see in here. But people, process governance, and data quality are really the major factors to ensure success in the AI space. Just to give you an example here to what we call the data science lifecycle, or the artificial intelligence factory that we follow within Oracle Cerner. We always start from the scope. So if we were approached by a client, by a physician leader, saying that we have a lot of data within a certain patient cohort that we'd like to analyze, we'd like to understand, we'd like to run into a machine learning algorithm to come up with insights that will improve our decisions. So this is just a very generic example. The most important step in all of this is scoping. To clearly define the problem, to understand if others have looked at this problem in the past, review the literature, make sure that we have the input from the right people, the right experts, not just within the organization that we're talking about, but also across the entire industry, to make sure that we are capturing all perspectives and understanding what are we trying to solve within this new AI or machine learning model that we're trying to build. Once that's clarified, really, then it's a matter of an ongoing process of collecting the data, prepping the data, cleaning the data, which takes a long time if that process is not automated one way or another, visualizing the data to understand what kind of initial and primitive insights can give us before we go into developing the model, which is the third step, where we start engineer the features of the model, select the type of the model, train it, evaluate it, validate it with real life. That's immediately before deploying it. And the deployment here is really, how can we operationalize whatever model, whatever machine learning model that we came up with? And going back to the cycle that I presented at the beginning, embed back into the health information system, if it's a clinical model, to make sure that those that require that information, that requires the guidance from the artificial intelligence model, get that support at the right moment that they need it. From there, we always monitor our artificial intelligence models and make sure that any opportunities for improvement are scoped again, and we go through the process on and on. Having explained to you now how we approach the development of machine learning algorithms within Oracle Cerner, and what are the key success factors for any organization to succeed with such an endeavor, let me start just giving you a few examples of what we were able to do here in the region, particularly the Middle East region and beyond, across the world. So starting with models that improve outcomes, improve decisions. One of the main examples that I'd like to share here is our readmission prevention algorithm that's embedded within our health information system that we provide to our clients. And what we really do is look at many factors, many clinical data sets, multiple attributes of every single patient that walks into any of our client facilities, and identify what would be their risk for a 30-day readmission, or what would be their risk if they're coming to the ED department to come back within a 72-hour window. Just by applying that and giving clinicians immediate support and immediate information that is automated through the machine learning algorithm to tell them, well, this particular patient will need 1, 2, 3 to ensure that they don't get admitted. We have achieved a lot of the results that you see in front of you. Northern Arizona Healthcare decreased their readmission rate for congestive heart failure by almost 50%. And the same applies to the many other organizations where they are relying a lot on our readmission prevention algorithm to support delivering a proper clinical care to their patients. Another example that we have done here in the region is the predictive diabetes disease control algorithm or model. We really wanted to look at a local population here in the region, because we know diabetes is very prevalent in our region, and we wanted to risk stratify that population to understand who are the patients at higher risk of developing complications with diabetes that will require personalized care, more engaged care, and that will be required to be empowered within the care that's being provided to them, compared to those that are well controlled, that don't need a lot of investment from the healthcare the healthcare institute to make sure that they are stable. And we collected data on more than 60,000 diabetic patients in one of the countries here in the region. We analyzed the data, we did the risk profiling, and as you can see here on the right-hand side of the slide, we found that patients who are male from certain nationalities, Bahrain included, unfortunately, within a certain age group, and have certain clinical and personal attributes at a higher risk of developing complications and being uncontrolled as diabetic patients. From there, we embedded that back into the HIS to make sure that physicians pay attention, to make sure that these patients are flagged, and start giving them some recommendations on how best to treat those diabetic patients. Another example is our model that predicts inpatient admissions from the ED department. The flow within the ED department is always a challenge for any healthcare organization. Ensuring that flow is smooth, ensuring that the turnaround time of patients within the ED department is very important, not only in managing the operations of the organization, but also in managing the costs of the organization. And the speed of admitting those patients, the inpatient wards that require admission, makes a huge difference in the capacity of the emergency department. Again, we analyzed a lot of data. We created our machine learning algorithm. We have validated that. And we found that our algorithm was more than 85% accurate in predicting patients from the outset, from the minute they walk into the ED room, the minute they walk into the triage room, and the nurse collects data to triage the patient. The system actually predicts that this patient has certain X probability to be admitted and get flagged to be admitted to the inpatient wards. And as you can see here in the graph on the right-hand side, out of those that were admitted, our system predicted 91% based on the population and the sample that we have gathered. And when I say our system, I'm not only here representing Cerner, but also representing Cerner clients, because it's always a partnership. In your respective organizations, it's always a partnership between your organization and that HIS vendor that you are working with. And just by working together, you will be able to achieve limitless things within the AI space, like what we are achieving here, which has resulted into significant improvement in the flow of patients and the bed capacity, and making sure that we have the right bed capacity for admitting those patients to the inpatient wards. The final example of using data to make better decisions is taking it to the next level and not remaining within the clinical space, but really looking at the financial space. Going back to the point that Bahrain is moving into a national health insurance program, and the impact of that on managing the financials of any organization. One of the examples that we worked on is actually a prescriptive, rather than only a predictive, a prescriptive financial machine learning algorithm that goes into every single claim within the insurance queue, and recommend and prescribes, using the right term here, prescribes to the revenue cycle clerks which are the first claims to be processed. That's based on the risk, with the probability of getting paid for the organization to get paid or not, and the value, the dollar amount. So we are able to rearrange the priority for the revenue cycle clerks to make sure that your organizations, your health organizations, get their money as soon as possible to sustain their operations. These are just some examples on using data to bring in more intelligence into our work and the decision-making process. But now let's close the entire loop and the cycle and see how some of our artificial intelligence models were re-embedded, put back into the clinician workflow to make sure that we are not only improving their decision making, but we are reducing the cognitive workload on those clinicians. We have all heard about the other pandemic that's happening right now, in addition to the COVID pandemic, which is the clinician burnout pandemic. One of the biggest reasons why clinicians are suffering from burnout right now is technology, particularly HIS and EHR, and making sure that technology is starting to work for them rather than working against them is where artificial intelligence really comes in. And I'll just share with you 2 quick examples before I wrap up. The first example is really built on our process of capturing everything that will contribute to the artificial intelligence process and factory to make sure that it's properly embedded within the workflow. So we're talking about artificial intelligence input in here. So we collect a lot of voice, text, image, video, and sensor data on our patients and also surrounding our clinicians that are using our system. Then the next step is transforming that data, whether through natural language processing, natural language understanding, text to speech, even skeletal tracking with all the sensors that we add to some of our patients to evaluate their musculoskeletal system. Once we transform that data that we got from the input modules and sensors, we run them through our own semantic interoperability models, through our own knowledge graphs, our own ontologies and medical terminologies, before we embed them back and bring them back to the workflow and the HIS. We have so many examples. I'll just share two of them with you, the chart assist and the virtual scribe. First one is the chart assist. The way that we do it is we look at the structured documentation within the HIS, the unstructured documentation, the free text that goes into the HIS, and the chart data that's coming from devices, that's coming from monitors. We run all of that into our Cerner ontology, our knowledge library, to make sure that everything is properly mapped. And this is where the semantic interoperability magic really takes place. Before we embed it back into the provider workflow and also provide the provider or the physician or the clinician with further clinical decision support to clarify why the system is doing this. Clinicians always look at machine learning algorithms and models as a black box, right? We have data going into a box and an output, an outcome or recommendation coming out the other side without really understanding what's happening in between, which is the machine learning algorithm. And adding that clinical decision support clarification to the workflow of the physician makes a huge difference. One of the examples that we worked on is to make sure that physicians don't need to exert additional effort to document for the patient. So I'll just give you a few examples. When a clinician documents a few words about the health, the history of present illness, about the physical examination, and does some lab investigation, the system will look at all of these entries and then suggest the proper diagnosis based again on the machine learning algorithm that we have established. In this case, the patient had low sodium, had some dehydration, nausea, vomiting, and the physician started normal saline. The system will immediately suggest to the clinician that most probably the best diagnosis for this case is hypoosmolality and hyponatremia. Another use case for this machine algorithm is actually to add a specificity to the diagnosis. Again, back to the National Health Insurance Program and the importance of being as specific as possible and documenting the diagnosis for every patient. The system does the same thing. If the physician places an unspecified diagnosis from ICD-10, AM, CM, whatever the catalog that we are using, the machine learning algorithm will nudge them and encourage them and suggest to them the proper specific diagnosis. And the last use case around this particular algorithm is when a clinician places a diagnosis, but they did not do the right documentation, they did not do the right management or treatment for the patient, then the system indicates that there are things that need to be done for this particular patient, and here's our recommendation. That's one example of how we embed the artificial intelligence modules within the workflow of the physician or the clinical user. The second one is really trying to eliminate all of the work that physicians are doing right now on the keyboard and using the mouse. We want to eliminate the monitor between the patient and the physician. And this is where a lot of the technologies come together. So we have created sort of a kit that includes a lot of sensors within the physician office, within the physician clinic, that listens to the physician, that looks at the physician and the patient movement, that also listen obviously to the patient, so that the physician and patient can undergo their visit in a natural way without technology sitting in front of them and between them. And the technology will collect all of that information and complete the documentation for the physician, so that they don't bother and don't have to handle that burden of clinical documentation. Obviously, you'll be able to review it, but a huge part of that work will be done. We found it to reduce up to 75% of the time that is usually required by clinicians to document into the EMR. Let me wrap up by just showing you a quick video of how that technology actually works and what kind of benefits you can get out of it. It's just a short video of 1 minute. I hope you enjoy it.
Hey, Dr. Nadeau.
What brings you in today?
Well, you know, I've been kind of feeling a little down lately. My asthma's been acting up and my albuterol's not really working. I don't know, I just feel kind of depressed.
Well, let's see what we can do for you. So I saw you were already taking Wellbutrin 150 milligrams daily. What happened with that medication?
I was getting really dizzy and I started getting really bad dry mouth, so I stopped taking it.
How is your sleep?
Not good. I was getting 8 hours and now I'm lucky to get 2.
Well, why don't we do some changing on your medications? Do you have allergies to medicines that I should know about?
I'm allergic to shellfish, but I'm pretty careful about it.
Okay, let's switch your medications. I want you to stop your Wellbutrin, start Prozac 20 milligrams in the morning, and then at bedtime for sleep, take Seroquel 25 milligrams. Remember, that is a sedative, so be careful with that. And then I'll see you back in about a month and we'll go over your progress. If things aren't better, we can always incorporate therapy at that time. Okay, so how's that sound?
That sounds great. Thanks, Dr. Nadeau.
Great.
And with that, I'd like to again thank Dr. Jassim for the invitation, and thank you all for listening. I'll be around for a while for any questions, but otherwise, thank you so much.
Thank you, دكتور محمد. نشكر الدكتور محمد الريس على هذا العرض الشيق. أما الآن يشرفنا دعوة الدكتورة آمنة الشحي، الأستاذ المساعد بقسم الهندسة الطبية الحيوية بجامعة خليفة بدولة الإمارات العربية المتحدة الشقيقة لتقديم عرضها، فلتتفضل مشكورة.
السلام عليكم ورحمة الله وبركاته. Thank you so much, Dr. Jassim and Daran, for the invitation and the introduction. So today I'm going to talk about machine learning for survival analysis to predict dementia risk using electronic health record or medical records. So my talk will focus on a specific case about how we apply machine learning in real life. So the outline of this talk will be, first, I'm going to talk about dementia to give you some introduction about the problem. Then we will talk about the effort so far in terms of the literature, what has been done so far in terms of applying machine learning to this problem. Then we are going to talk about the approach or the methodology that I follow and for analyzing the data that we have. Finally, I will talk about conclusion, limitation, and the future talk. So in the first section, I will try to define to you the problem by defining what's dementia, what are the risk factors for dementia, why we consider dementia as a biomedical challenge of our time. We also will see why it's really important to detect dementia in its early stage. So for people who don't know dementia is actually consists of different neurodegenerative diseases that cause cognitive impairment that affect patient real life activity. And there are actually, as I mentioned, there are many diseases under neurodegenerative diseases under dementia. All those diseases share common characteristics, like they are chronic. There are no cure for them until now. They are caused by a damage on the brain cell, and the type and the symptom of dementia depend on the brain region that affected. Some people think dementia is a normal process, normal aging process, but it's not. It's a disease by itself. Also, Alzheimer's disease is one of the well-known dementia type. Looking at dementia stage, in general, we have 3 stages. For sure, there are other stages that can be embedded inside each one. The first stage, which is a pre-symptomatic, in which the patient don't have any kind or any symptom of the disease. Then when we have MCI, which is mild cognitive impairment, in which very mild symptoms of the disease will start to show up in the patients, but those symptoms will not affect the patient's daily life activity. And finally, we have dementia, in which the symptom become clear. It will start to affect the patient daily life activity until, unfortunately, it will cause it to death. It's important to know one thing, like some people can have a cognitive impairment, but that doesn't mean they have dementia. Sometimes it's because of other type of comorbidity that can affect their cognitive function. If we focus on this graph, we can see, first of all, the curve. So we can see the cognitive decline for normal aging patient is different than dementia patient. So as I mentioned, our Alzheimer's patient, dementia is a disease. Looking at the period of each stage of dementia, we can see in the early stages in which we don't have symptoms, the patient don't have symptoms, this stage or this phase lasts for 20 years or more before the symptom of the disease starts to show up, or early symptoms. Then we have MCI, which lasts for 2 to 5 years, depending on the patient. And finally, dementia, unfortunately, until it can cause the death of those patients. Looking at some facts about dementia. So actually, it's projected that the number of dementia cases will increase in 2050 to 13.8 million. I'm talking about US population. A part of that, if we see the cost, the average annual cost per patient to be treated for dementia compared to LD patients. So we can notice patient with dementia cost approximately $50,000. Unlike LD patient without dementia, which is $14,000. So it's really costly to treat those patients. So overall, dementia, actually, it's not only a disease. It can have like other side effects, like it has a physical, emotional, financial, and economic burden on the patient, as well as in his family, healthcare, and society. If we focus about the risk factor of dementia, so the risk factor or the causes of this kind of disease can be divided to 3 types. Unchangeable, like age and ApoE allele. Genetics, there are some variation of genetics that can cause dementia, or they consider a biomarker for dementia. And we have a modifiable risk factor. So if you focus about in this category about modifiable risk factor, like smoking, lack of exercises, less education, we can start to notice those modifiable risk factors can vary across the patient lifetime. So we can see in early life, less education can have some indication to develop dementia. In middle life, we have hearing loss, hypertension, obesity. We know like dementia patients, like obesity patient or diabetic patient have 60% high increasing for them to develop dementia. Then we have later life risk factor like smoking, depression, and many other. And actually those modifiable risk factors that we know so far are contribute like 40% of total risk factors. So there are still 60% risk factors that we don't know them. And they could consider modifiable because we can control them in some sense. It's important to know those risk factors are vary between continents and depend on the genetics and the population. So why dementia considered a biomedical challenge of our time? So actually, it's really hard to detect dementia in its early stage. So there are like 50% of LD patients live with dementia. And some of the patients can be diagnosed as dementia after like 2 or 3 from the symptoms start to show up to those patients. Unfortunately, until now, there is no cure for the dementia. And the medication that we are using currently just to reduce the symptoms of the disease. And finally, there is like a high failure rate of the clinical trial to find a treatment for dementia. And this is the main reason for this is it's really hard to find or detect the patient who will develop dementia to start to try to introduce any kind of treatment or intervention to prevent this kind of diseases. Looking at, if we back to the curve that show the stages of dementia, actually the early stage or a pre-symptomatic stage is really an important phase we need to focus on to prevent dementia. So if we manage to detect like this patient will develop dementia earlier than its early stage symptoms, we can start to work with those modifiable risk factors so we can at least delay the early symptom of dementia by 2 or 3 years, depending on what kind of intervention that will be proposed to the patients. Okay, so why it's really, so now I'm going to talk about why it's really important to detect dementia in its early stages. As I mentioned, first of all, detecting patients who are at a high risk of developing dementia will help the healthcare sectors to introduce some kind of intervention to delay the disease progression. Those patients who didn't develop dementia, but we know they will develop it, can be a good candidate for clinical trial to try to find a treatment for dementia. And by doing that, actually, we will save a significant amount of money. Instead of using those money to treat dementia, we can delay it. So it will be beneficial in terms of economy and in terms of the patients. So the current research or what I'm going to try to address, or research question that I'm going to try to address in this talk is, can we develop a new machine learning models for survival analysis? It's a specific type of machine learning model using electronic health record or medical record to identify patients who are at a high risk of developing dementia. So why electronic health record? So we know we have like MRI image, we have EEG, ECG, but why we are focusing on electronic health record? So electronic health record, you know, it's the record that the doctor keep when the patient go visit the doctor for any kind of diseases. So apparently those records can have an early warning sign that this patient will develop dementia by, for example, monitoring the risk factors of this patient before the early symptom of the disease will show up. And by doing that, we can actually screen a lot of population, the huge population, to try to define patients who are at the risk of developing dementia. It will be automated process, it will be cost efficient, and it's actually non-invasive. So, and as I mentioned, it will be cost effective and it's pre-screening. So the data there, we need to just run the algorithm on the existing data, and the model can propose to us, okay, those patients are at high risk, let's focus on them or try to do intervention. So now I'm going to talk about what exactly in literature about how we can use machine learning model and analyzing electronic health record for dementia prediction. There are a lot of effort recently started, especially with using electronic health record, because previously people focused on MRI images, but nowadays the shift has been toward electronic health record. And here, as I mentioned, I'm talking about machine learning model, not machine learning for survival analysis model. There is some differences between those kind of models. So early models was focused on logistic regression, basic models. Then we can start to see like support vector machine, logistic regression, gradient boosted model, or tree-based models start to take over. And recently, like in 2020, a lot of papers start to apply machine learning. So in the beginning, we have only one, then it starts two, then there are a lot of research dedicated to trying to use electronic health record to detect dementia or the risk of dementia. Unfortunately, all those methods, or the main limitation of those methods, that they consider the problem as a classification problem. So when they deal with the issue, they consider if the patient will develop disease or not. So it's just a simple classification problem. This kind of model will not tell me when the patient will develop the disease. Is it after 1 year, 2 years, 3 years? We don't have this kind of information, but I know this patient will develop it or not. So now I'm going to talk about what the work or the model that we address and use in the study. So here, like the methodology pipelines, it's the basic pipeline in any machine learning model. We follow the same process for machine learning for survival analysis. So first we have our data set. We start to extract patients' baseline information. Then we divide the data to training, testing, and the training, for sure, we have a lot of pre-processing to the data, how we fill in missing data. Then we do like feature extraction using, for example, here we use the bootstrapping. Then we use, like, for training, we need to consider hyperparameter optimization. We use 5-fold cross-validation. Then we select the best model, and we validate the model based on the test set that we separated. For the data source, we actually, for this study, we use 2 data sources to predict if the patient would develop dementia or not. So the first data source focus on all types of patients. So we have a small number of patients because really it's having or acquiring electronic health record is not easy process. In the data set 1, we extract facial like age, gender, education, and different cognitive test results for those patients. For data set 2, we try to focus on diabetic population because we know like diabetic patients are and have a higher risk to develop dementia. So if you focus only on this population, and for this population, we also extract some information or feature from about the patient like age, gender, and other comorbidity, smoking status, and those stuff. So it's important to note, as I mentioned, this type of model, or what we call machine learning for survival analysis, we need to extract the information at the baseline, okay? And then during the training, the output of the model, which will be a risk score, we need to make sure to provide to the model the status of the patient and the time when the event happened. So that way it's different than any classification problem that have only yes, no outcome. Here it's like the status in addition to the time of the event. A part of that, we know like in healthcare sector, like we lose some information about specific patient. Maybe the patient will die. Maybe the patient will change the hospital. So for those patients, we have incomplete information, and in machine learning for survival analysis, we consider them as censoring. So those kind of model can address like if we have missing information. That's why they are so powerful. For sure, similar to any machine learning, we have feature extraction methods, so that account for censoring or time to the event, like we have random forest using variable importance. We have univariate scoring using survival tree, Cox model, permutation, mutation. It can be used also as a feature extraction. And all those models will account like we have censoring in our information and addition to the status and the time of the event. For survival analysis model in this study, we applied first Cox model, and Cox model is one of the well-known model, statistical model that use in healthcare. So it can be like our benchmark in this study. We have regularized a generalized linear model that focus on lasso and rigid models. We have survival tree, survival random forest, gradient boosting machine for survival analysis. And as I mentioned, those models consider like the survival probability or the curve of the patient to develop the disease or not. Similar to traditional machine learning, for those models also we have different hyperparameters that we need to tune and select the best model. So based on the outcome, here we can see the average C index for the 5-year follow-up between the 2 data sets. So we train the model. The outcome of the model is C index because, as I mentioned, in this scenario, we are caring about the probability curve or the risk score. So we use C index. If we see, like, we compare the performance of the model and the 2 data set, we can start to notice when we selected the diabetic cohort Data said to machine learning for survival analysis give us a high accuracy, which is 90, based on the C index. Okay, and comparing like when we use like or the patient, whatever, without being more specific about the cohort. Looking at the performance of machine learning for survival analysis in comparison to the baseline, which is the statistical model, Cox model, we always notice like machine learning for survival analysis perform much better than traditional statistical models to predict if the patient will develop dementia or not. So now in conclusion and limitation on the future work, so we can start to notice like a pre-MCI stage is really important stage for us to introduce intervention to delay dementia. And electronic health record, it becomes so trending nowadays for a doctor to try to stratify patient or detect patient who are at a high risk to develop dementia. And finally, as it's a clear, machine learning for survival analysis outperform the traditional method using, I refer to a Cox model, which is the famous and well-known model for in a clinical studies. There are a type of model that we call deep learning for survival analysis. Fortunately, currently, those models didn't outperform machine learning model, but I think there is a huge potential for those models to be improved, to improve our prediction if the patient will develop dementia or not. For sure, as any study, we have several limitations. First of all, there are many risk factors, and in this study, we didn't include all of them, even though we didn't include the model perform well. But for sure, if we add more and explore more features to the model, we will improve the model accuracy. Apart of that, we might detect a new risk factor to the disease that haven't been reported. Second, in clinical practice, actually, whatever model I will implement it for specific cohort, I cannot generalize it because there are many other factors that can affect the patients in terms of developing the diseases or not. One of them is like the differences in healthcare or provider services. And as I mentioned, so for future work, for sure, we will try to add more features to the model to try to, if we can manage to get a new risk factor to develop the disease. And if we manage to get something really interesting, we can apply those models to hospitals so they can, for early identification of patients who will have the high probability to develop dementia. So that's it. And thank you so much for your listening.
Thank you دكتور آمنة. نشكر الدكتورة آمنة الشحي على هذا العرض الشيق. الآن يشرفنا دعوة الدكتور محمد المدفع المعيد بكلية الطب والعلوم الطبية بجامعة الخليج العربي لتقديم عرضه، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. أول شيء حاب أني أنا أشكر الدكتورة جليلة بنت السيد جواد على رعايتها الكريمة لهذا الحفل، وودي أني أنا أنتهز هذه الفرصة لتهنئتها لنيلها الثقة الملكية السامية لتأدية مهامها في أنها بتكون وزيرة صحة إن شاء الله. وحاب بعد أني أنا أشكر الدكتور جاسم حاجي على دعوته الكريمة، وأتمنى أن الكل كان مستفيد وبيستفيد إن شاء الله في هذا المؤتمر. طبعاً with all of that out of the way, first of all, I would like to give you an outline of my presentation. As the title suggests, I will be talking about artificial intelligence in radiology specifically. I will give you a simple introduction into the subject, and then I'll give you a more tangible thing to grasp, which is the current real-world applications in radiology. Being a doctor first and a scientist second, and also not too long ago, being completely oblivious to all of the terminology in this field. I'm going to try my best to keep this very simple and use simple language and simplified explanations so that it can be digestible to everyone here with us. So again, with that out of the way, let me begin by giving you a simple introduction. My colleagues have spoken brilliantly about what artificial intelligence is and what machine learning is. So I'll just say something simple, which is artificial intelligence basically is the use of statistical algorithms to help and to augment physicians in their everyday tasks and in the decision-making process. Now, I've used augmented here instead of artificial because many experts in the field are opting to use augmented due to the fact that artificial intelligence is not here to replace physicians. It is here to augment and to make their jobs and their lives easier. So that is why the designation augmented instead of artificial. Now, the types of augmented intelligence in general, we have general AI and we have narrow AI. So the general AI being what you see in movies and what you probably heard that recently Elon Musk from Tesla has unveiled a humanoid robot which can do multiple tasks. So that is the vision, that is the future, having general AI that can do many tasks at a given time. But for now, we are utilizing narrow AI, which is using artificial intelligence for a simple and a very specific task. So it is reserved for mundane and or labor-intensive tasks and made with cost and efficiency in mind. And then it is utilized by the use of machine learning and deep learning. Now I'm going to give you a simple outline of machine learning and deep learning. So as I said before, it is the use of statistical algorithms, and machine learning and deep learning are actually subsets of artificial intelligence, and they can be employed in many ways: supervised, unsupervised, and semi-supervised. And I'll try to kind of ease you in how that exactly works as I go through my slides. So deep learning is a subset of machine learning, and it is the sort of the more advanced and more computationally demanding subset, and it is more powerful, if you will, than machine learning in a lot of ways, and I'll try to also ease you in on that as we go along these slides. So this is just a diagram to kind of outline what machine learning is and what deep learning is and how do they work. So on the left-hand side, if you can see, we have, let's assume that to be a chest X-ray, for example, and then we have a lesion there. So let's say the main difference between machine learning and deep learning is that in machine learning, we have to use annotated data, okay? And I think Dr. Mohammed Al-Rayis spoke brilliantly about data and how it is curated and how it is used. And by annotated here, I mean that generally an expert has to label the image. So for example, if we have a lesion there, an expert has to come in and say that this is, for example, a lung nodule due to lung cancer, for example. And then given that label or given that annotation, we can predefine some features. If you look at the top of this diagram, this is using machine learning. So to define features, we'd say, for example, this nodule is, we'll talk about the size, the shape of the nodule, the edges of the nodule, the texture or the density of the nodule. So all of these are features that we can encode to the machine learning algorithm. And then that can be used to sort of give us an output or to classify the lesion as, for example, malignant or benign. And then deep learning, and also Dr. Mohammed Al-Rayis mentioned this, that many say that deep learning is a black box because, as you can see here on the bottom of this diagram, that there are many hidden layers in the middle. And maybe when people first started using deep learning, there weren't much methods of interpretability. But nowadays we have interpretability methods that I'll go through later on. But as you can see here, we just give the label to the computer, and then the algorithm itself, the deep learning algorithm, just extracts those features that I spoke about earlier, for example, the shape, the size, the texture, and the density. We don't have to explicitly tell the algorithm all of that. It just extracts that on its own and classifies the problem. So you can glean kind of that this can be very, very powerful if utilized correctly. Now moving on, in radiology, it can be applied anywhere across the clinical radiology workflow or pipeline. And I'll show you the pipeline of this radiology or the workflow. As you can see here in this diagram, we have first acquisition of images. So for example, let's say the patient comes in the CT department and gets an image. That is the acquisition part. And then the pre-processing part is done by the technologists. So for example, they change the image to the Hounsfield scale, and then they crop, they tilt the image. So that those are the usual pre-processing steps that go into the clinical radiology workflow. And then we get the images and we upload the images. And then AI is mainly being utilized in this part of the workflow, which is the image-based tasks. And I'll speak about each one of those image-based tasks, which is the detection, characterization, and monitoring. So going forward, first of all, the detection of lesions. So for example, we use machine learning or deep learning, as I specified earlier, by being either supervised or unsupervised. Supervised meaning that we label the image, we annotate it. So we tell the machine that this, for example, is a malignant lung nodule. So the machine knows that. And unsupervised is when we do not label data. So we give the machine learning algorithm the image or the lesion, and we have the machine learning algorithm itself tell us whether this is a benign or malignant nodule, for example, by it extracting the features on its own. And then, the goal of this detection process is to divert the radiologist's attention to an abnormality for further evaluation. So this is not the diagnosis part, it is just the detection. So we can just, a lot of applications that I'll be speaking about later on is just to tell the radiologist, hey, we have an abnormality here, can you please look at it? So it's just to divert the radiologist's attention. And then moving on to characterization, this characterization step can be subclassified into three main tasks. We've got segmentation, we've got diagnosis, and we've got staging. So segmentation, as the name suggests, is to segment the image. So for example, we want to segment, let's say the machine learning algorithm recognizes that there is an abnormality, for example, in the left lung. So we can segment that part so that the radiologist can put his entire focus into that part. So this is what segmentation does. And then another thing is that we segment the non-deceased organs. So we just exclude all of that out of the way. And then so that the radiologist also can have the full attention. And then the diagnosis step, it detects abnormal areas in two ways. Again, it comes with supervised and unsupervised. So supervised, the characteristics of abnormal areas are supplied, and then they are used as features. So for example, the shape and the size and the density, and the algorithm itself can tell us what that lesion is. And then the unsupervised, we automate the feature extraction with the help of neural networks, which is the deep learning that we spoke about earlier. And then the staging task, the staging is a bit difficult. There are some applications going into it nowadays, but it is still not there yet because staging is more of a qualitative process whereby, for example, we have the TNM staging, which is the tumor node metastasis. So we have to look at the size of the tumor, the extent of the tumor, and we have to look at how many lymph nodes are involved, and we have to look at what sort of organs are involved in metastasis. So it's kind of difficult to put all of that together into an algorithm. So for now, it is mostly carried out on pathology images. This is just a diagram of the segmentation process. So you can see here we have an MRI of the knee, and the segmentation, what it's doing is that it's just segmenting the lining cartilage. And you can see that on the right-hand side, we just have the lining cartilage of the knee segmented out of the entire MRI sequence. Next, we have monitoring. So in monitoring, the main thing that is employed is something called computer-aided change analysis. And this basically, what it is important for is it is important for monitoring, for example, tumor response. So we have a patient with lung cancer, for example, and we're giving him chemotherapy. And then over time, when we take more images, we kind of try to look at the differences in the tumor size and tumor shape and tumor density. And this can be done over time from different sequences. And the earliest form of that was done by image stacking and subtraction. And then we look at the difference in the pixels. And that tells us if there is a change or not. And now, of course, with machine learning and deep learning, it is a much more, let's say, a better process whereby we can find the features. But it is also cumbersome because the problem is it's going to be labor intensive because we're going to have to, let's say, label and put some features on, for example, the first image. And then when we get the next temporal scan, we have to put another set of features. And this can prove to be very cumbersome. So it is sort of difficult to do. But now with the introduction of deep learning, feature engineering is not required, as I spoke about earlier, so that will be a much easier process. Now, other areas along the radiology workflow, if you remember the diagram that we saw, we have the pre-processing steps, and there are some efforts to, for example, suppress artifacts by use of machine learning and denoise MRI sequences. And I have an example here, if you can see. This is an MRI sequence of the brain. And what they did in the study was that they simulated motion. So if you can see on the top part of this diagram, the A, B, C, and D, we have varying degrees of motion artifacts generated by an algorithm. And then on the bottom of the screen, we have E, F, G, and H. This is where a motion artifact suppressor was used. And you can see the difference. If you look at the top part of this scan, you can see for example, let's take D. You can see that there is a visible motion artifact on the top of the image. And when you look at H, it is completely gone. So this is another application of AI in the workflow and the pre-processing step to be more specific. And then we've got the reporting, and the reporting I feel is very important because as my colleague spoke about earlier, a lot of the time when we try to utilize machine learning algorithms, we are using electronic health records and we are using health data. So if there is some sort of way, and by some sort of way, I mean the use of machine learning, we can generate reports that are standardized and that are using the same language across all hospitals, across all health systems. This can prove to be very beneficial if we want to use that health data later on to build more algorithms for prediction purposes, for example, stratifying, let's say, cancer patients, and for example, in research purposes. So standardizing the language that is used can prove to be very beneficial. Now, this is all sunshine and rainbows. Machine learning is amazing, deep learning is amazing, a lot of opportunities, a lot of things there, but nothing comes without challenges. So the first challenge is data curation. And again, this is because, as I stated earlier, a lot of the images for the machine learning algorithm to use, the images need to be annotated or labeled. And this is actually very labor intensive because we have to get a radiologist to label all the images that we want to use for our training set, for our training data set. And we already know, and we already spoke about burnout and how physicians are really pressured and they have a lot of work on their hands. So adding that to their work schedule is proving to be difficult. And I think this is very important, the labeling and annotation. And maybe in the future, we can see some people incentivizing it. So for example, do 100 images and then you'll get some sort of incentive, if you know what I mean. So this is an important challenge, actually, because data is the most important thing for these algorithms to work. And then inconsistent performance, of course, this these algorithms, they have to be validated, they have to be tested, they have to be employed, and then they have to be revised so that we can mitigate this inconsistent performance challenge. And then lack of interpretability, I spoke about that earlier. Now, with newer models, they are trying to employ some form of interpretability, and I'll show you an image in a bit, where they use something called saliency maps. And this also ties into the next point, which is the undesired shortcuts. And I'll show you that in one single diagram. So if you can see here, we've got chest X-ray on the left, and we've got an algorithm that tells us if there is an abnormality on the right. Okay, and you can see the label on the chest X-ray on the left. It says that this is a positive image. So the algorithm is telling us that this patient, to just give you an outline, this study is checking whether these patients have COVID-19 or not. So the image on the left, the chest X-ray on the left, is telling us that this patient has COVID-19. And then on the right-hand side, we have what is called a saliency map. And what a saliency map does, it tells us that the algorithm is using these pixels. If you can see on the arrowhead, there is something lighting up in red. These are basically the important pixels that the algorithm used to tell us that this image is abnormal or this image is positive. Okay, and if you take a closer look, the image is telling us that the annotated R, if you can see it, this just tells us that this is the right side of the image. So the algorithm is taking a shortcut here. Instead of actually finding the abnormality, it is just using the R here, the laterality marker, if you will. It's using that as an important point to this patient being positive. So this is what undesired shortcut means. This is obviously a deep learning algorithm. And this just tells us, as I said earlier, that deep learning algorithms can be very powerful, but they have to be employed cautiously because things like that can happen. And so this diagram is just a way of me to convey two things, to convey the undesired shortcuts and to convey the interpretability method that some algorithms use. And then we have regulatory challenges, of course. This is an important question, I think, for everyone. Who will be held liable if any mistake happens, if any error happens, if the algorithm makes a mistake? Who will be held liable? So that is a very important question, I think. And I'll go through what the FDA is doing. And then ethical consideration, of course, this has to do with data, because these algorithms, they are very data intensive and they're using patient data. So can we protect the patient's privacy? That is a very important point to keep in mind. Now, current real-world applications, I'll just go through this quickly. Here I have for you a website. It is from the Data Science Institute of the American College of Radiology, if you want to take a screenshot of that, or if you want to visit the website. This just tells us the algorithms that are actually approved by the FDA as of now. And if I remember correctly, they were, yes, 193 algorithms currently approved by the FDA. And some examples here, this is actually a device, not a device and a software. It's something called a point of care ultrasound. And this is basically an ultrasound probe that you can connect to a tablet, connect to a phone even, and you can just do real-time ultrasound. And the newer iteration of this ultrasound is, if you can see on the mobile screen, the place where the needle is going in is lighting up in blue. And obviously they're using deep learning here to detect the needle. So it can make the life of a radiologist much easier. And then we have detection of breast lesions on mammography. This is another application. Another application is also here, as you can see it. It is detection of stroke, for example. And this is very, I feel like very helpful, because it can detect, for example, if a patient has stroke or if a patient has a neurovascular emergency, like intracranial hemorrhage, for example, and it can flag it and notify the physician to look at this image, make it a priority. So this can be life-changing actually for patients. Now, future perspectives. The goal or the future vision is that we shift from the static AI to continuous AI. And by static, I mean that we make a machine learning algorithm and we employ it in clinical practice, and then that's that. All good, let the machine learning algorithm work. But with the introduction of newer patients, for example, not all patients from all populations have the same baseline ECG, for example. And not all patients from all populations have the same baseline chest X-ray. So with that, the accuracy of the machine learning algorithm can actually decrease. So the goal is to completely or continuously reiterate the algorithms. The second point in the future perspectives is the Radiological Society of North America had a meeting in 2021, and over 100 startups were there to demonstrate their products. So what's going to happen in 2022? I don't know. And another important point actually is in the RSNA is that a lot of startups. So we want this process to be done by official governing bodies, not startups, because with the involvement of official governing bodies, we can have more rigorous and more robust testing of these algorithms. And again, the question of who will be held liable is also mentioned here. So to conclude my presentation, I just gave you an overview of what AI in radiology is, and that we are using narrow AI, a problem-specific AI. We have machine learning and deep learning. Some use, for example, in machine learning, we are using feature extraction. We specifically tell the machine what features we want it to look at. And in more newer iterations of deep learning, we don't really have to do that. We don't really have to feature extract. And then there are many applications ranging from detection to monitoring. Various challenges hinder the implementation, and I spoke about some of those challenges. And of course, there's going to be, actually within these past 5 years, there's been an explosive rise in research, especially in radiology. And possibly it's going to be even more than that in the coming years. So thank you very much for listening. Thank you, Dr. Jassim Haji, again for your invitation. And again, thank you to Dr. Jalila for her.
نشكر الدكتور محمد المدفع. يشرفنا الآن الدكتور محمد الحامد، مدير مركز الذكاء الاصطناعي بمستشفى الملك فيصل التخصصي ومركز الأبحاث بالمملكة العربية السعودية الشقيقة. لتقديم عرضه فليتفضل مشكورا.
All right, thank you so much, Dr. Haji, for the invitation. Thank you, Dalal, for the introduction. It is a pleasure to be invited and a pleasure to present today to you. So the title of the presentation is to highlight the potential of artificial intelligence in healthcare and to demonstrate the KFSRC, King Faisal Specialist Hospital and Research Center journey into adopting artificial intelligence and advanced analytics. A quick overview of King Faisal Specialist Hospital. It was established in 1975. 9.4 million of the population have been served in the hospital. The hospital holds 2,000 plus beds across Riyadh, Jeddah, and Medina. There are 31 smart centers for different medical services, and the number of operations, for example, in OR, exceeded 50,000 hours for the last years. So what is the Center of Healthcare Intelligence, and why was it established at the beginning? In 2019, we were very lucky enough to have this strategic vision where it focuses on the advanced technologies, specifically artificial intelligence, with the need of having something applied into the healthcare process. So this center is called Center of Healthcare Intelligence, which focuses not only on the healthcare side, but also on the multidisciplinary areas, for example, supply chain, human resources, and others. The goal is to focus on applied with highest immediate impact. This means we're not focusing on driving research in the domain of healthcare using AI, but also applying AI to the healthcare process itself. And there was a strategic decision to be taken whether we should be focusing on third vendor solutions, or we should be able to build our own solutions driven completely by the use of the latest technologies. We're lucky enough to have leaderships to support our vision of having in-house developed solutions completely driven by the need of the hospital. So in 2019, couple of months after the establishment of centers and the hiring of the early members of the staff, the COVID-19 hit later, and that was the first challenge where the center has to really prove itself to bring some advanced technologies to help mitigate the risk of COVID and on the pandemic itself. So the first thing we were focusing on at the beginning was we need a strategic roadmap, and not from a project perspective, but also from a technical point of view, like the skills needed, where we think the AI is going, and where we should be focusing on, and all of that together. So the first things we set is that we need to build up the structured data and AI capabilities. We want to know if we are able to build and accelerate the building of machine learning models to estimate and forecast, predict, classify, and do a lot of machine learning related stuff based on the data that's being structured in our data warehouses. And following that milestone, we moved from structured data into unstructured data, where natural language processing techniques were used to, for example, understand the medical notes, extract entity from textual components, and identify a potential of classifying notes according to the codes, etc. And the next milestone after the unstructured data, obviously, is the second form of unstructured data, which is basically the images, and all of the X-rays, MRIs, and the pure regular images are the focus of this kind of milestone, where we wanted to use computer vision in order to do a lot of detections and diagnoses related to healthcare, and also at the same time bringing up the skills required to build up the medical imaging pipeline, which is really very important. And then where we are right now is that we are working closely with the genome centers here in King Faisal Specialty Hospital to leverage not only AI, but also the genome sequencing and analysis in order to really build up the capability from both perspectives, seeing and analyzing the data that's coming out from the MRs, but also the genetic side of the patients, where we wanted to combine the power of understanding data from both perspectives. We also utilize blockchain, for example, for another technologies to enable us to have the foundations to enable the infrastructure of the data itself. Where we need to build up for futures is we wanted to build up the AI capabilities when it comes to casualty analytics. This is a huge topic that we're predicting it's going to be coming up extensively in the coming few months, if not a few months. But the idea is that we want to know what causes what. For example, what is the diagnosis is it caused by from all the lab tests that we have been collecting, from all the historical information, the medical history that the patient has. We do have a couple of 3D printing started already, so we can see, for example, we're accelerating on using advanced technologies, but where we want it to be is we wanted to build up the knowledge sharing, where things are mitigating from different kind of models into a comprehensive view about the patient, of what do they, how do they are doing, how we can do the preventive versus diagnoses type of models, etc. And at that time, we wanted to really focus on a few important things. For example, what are the maturity of the organization to apply an AI. So we came up with these 5 important pillars. We says that we need governance. We want to make sure that we have a digital health strategy, and we want to clarify the KPIs needed and where those KPIs going to be reflected into the strategy of the organizations. And also we need the human power, which is basically the data scientists and machine learning engineers to be involved, specifically to have the understanding of healthcare and leverage all that engineering perspective into the healthcare domain. The third milestone or the pillar is the infrastructures. So basically we do have warehouses, we do have different systems saturated on a different campus of the hospitals. But what is more important is we needed to make sure that the real-time access to data is there. The back system, for example, for the medical imaging is able to retrieve MRIs, images, etc. And we do have the machine learning pipelines to train up models, to validate them, to deploy them, and also to continuously learning the new features when it arrives. The 2 other things is that we cannot do this without having the proper awareness. So we conducted a couple of awareness sessions to the staff of the hospitals to make them aware of what AI can do and what machine learning can drive. And this is really important because what we believe in, that's all the proposals to apply artificial intelligence has to be coming up from the point where the physician understand and clinicians in general, they understand the need, they understand the shortcomings, and they wanted to drive data-based decisions where possible. And in order to do that, we need to collaborate with universities. So we have a couple of universities and professors who also help us validate the methodologies, the algorithm that's being implemented for different use cases. And on the governance, I just want to shed some light on this important topic because data is very sensitive and it violates the privacy of patients if no proper governance is being taken seriously in place. So what we come up with this model simply is that we have a domain expert where they write proposals for where they think the artificial intelligence has a potential to be applied in. And those proposals goes into what we call the artificial intelligence specific AI groups. Those AI groups, they know the domains, and plus we have experts from the AI side as well. So across the organization, we were able to build up 15 plus groups from radiology, surgery, for example, ambulatory care, etc. And all what they've been doing is assess the proposal coming up to them and validate the return on investment and monitors the validation process and the governance in terms of data being collected, the type of the data, quality, etc. And on the top of that, since we might have a lot of proposals right and left, we wanted to make sure that there is an executive committee that's aligned what the organization needs to be focusing on in terms of implementation and investment. In addition to the governance groups, obviously we need to also the execution governance, where we want to make sure that every single proposal approved by the AI groups has to be going through literature review and extensive literature review to understand what have been done in this domain, what are the solutions available today by vendors, and mitigate any kind of risks in terms of data availability. And then we do an extensive data collection with ADA, was basically we do an exploratory data analysis to understand if there is a skewness in the data is being available, it has the right quality, and no missing data obviously is being disturbing the implementation of this model. And then once everything is done, we do feature engineering. It's an iterative process where we try to transform some of those features or generate new ones to enhance the model accuracy accordingly. In terms of model performance and model implementation, is an iterative process where we continually do feature engineering, feed them into the model training pipeline, and then validate the accuracy of the models. Once the model is reaching this stabilized stage where the stakeholders are happy with the results, we do an internal and external review. So the internal will be the main PI of the project, and the external will be the professors from the universities who help us understand that the methodologies are correct. There is no bias in the data that's being collected, and the feasibility of the models be applied into a clinical care process is approved. Once we do that, there is a validation where the model is being put into the clinical process carefully, and the governance is making sure that the model's prediction is being documented, and any false predictions or any feedback from the owner of the models should be captured. And again, this is an iterative process where feedback loop in machine learning is very important key. Any model being put into production has to have the methodologies of capturing how the model is performing to avoid any kind of regression, and enable the model to generalize over time and being able to capture new patterns being seen in the data. In terms of the pillars of human resources, we have the leadership on the top of the organization to overlook the AI work, and the main 4 pillars or the main 4 teams are the core data scientist teams who are building the models along with the researchers from the universities. Internal champions, we refer to them as the main clinicians who drive the proposals at the first place, who really believe in what we are trying to do, and who will be the end users at the end of the development phase. The external collaborators, we sometimes wanted to collaborate with different hospitals because sometimes the data are not enough to really generalize over new cases or unseen cases, and external collaborators is really powerful in specifically when it comes to machine learning and data. Because I don't want to be too much technical, this presentation more like eye-opener where AI have been applied in healthcare. So all the use cases I'm going to be showing are fully deployed in King Faisal specialist hospitals, and they are completely in-house developed, so developed completely by the team in King Faisal. So for example, on the operational side, we do a lot of forecasting. For example, ER in emergency forecast on an hourly basis, how many patients will be arriving at ER and to what volumes, and periodically we calculate the waiting time. So this is important. So we continuously monitor the arrival of patients, how they've been waiting into the ER during different kind of steps. For example, when have been seeing in the triage, when they have been first seen by the doctors, up to the end where there was a decision to discharge or to admit the patients. And on operation side as well, with since I talked about that center was facing the COVID situation at the early stage, there are lots of models have been where not only from a medical side of the story, but also from the operational side of the story. So, for example, we have a number of patients positively diagnosed with COVID on a daily basis, and those numbers are being also shared by the Ministry of Health in Saudi Arabia, and also by private organization that collect statistical information about the situation of COVID worldwide. So based on all that information, we try to predict the number of patients who will be arriving in King Faisals, and accordingly we do what-if scenario. So we told the infection control units that this is the number of patients who will be arriving tomorrow, very likely. And these are the what-if scenario. If the number of patients were 10% more than what we are predicting, then this is the amount of resources needed in terms of gloves, gowns, respiratory machines, staff, etc. And accordingly, we do kind of forecast also the the severity of the patient. So, for example, if the patient being diagnosed, we know that he has COVID or she has COVID, we want to estimate the severity of the situation of the patients. This will reflect the length of stay. So, for example, the bed capacity is completely can be predicted by understanding the severity of the vital signs being collected from the patient. So, in order also to to build up diagnoses related predictions, we do have a couple of use cases. For example, we build up a use case for prioritizing CT scans for chest X-rays. So we on a daily basis there are almost between 150 to 200 X-rays being taken. So this is a huge amount of X-rays being taken across the different branches. But what we wanted to do is that we wanted to make sure that the clinicians have the right access at the right time to the most critical cases. So we don't want it to be first come, first serve. We want it to be a little bit more intelligence, where the time of the radiologist is being focused on the cases that we think it has a critical dimension. In order also to put a patient in the centers, I'm going to show a couple of use cases where we analyze, for example, the satisfaction scores in order to predict how likely the patient will be happy when they visit the clinic. This will reflect the patient satisfactions and the journey on overall the services provided by the hospital. We do have, for example, a couple of capacity control when it comes, for example, the predicting the number of prescriptions in different pharmacy of the hospital. For example, in the campus in Riyadh, there are 3 different pharmacies serving the patients, and on a daily basis we try to predict how many prescriptions are needed to be delivered based on the number of appointments we're seeing, and in the MR the number of patients usually coming at this hours, and also the number of prescriptions based on the diagnoses that we are seeing in the data. Just to highlight a little bit of more details. So the first thing that we started with is we wanted to empower a feasibility toolkit for data discovery. So we want to make sure that the physicians, before they submit their proposal, they want to understand how many, for example, diagnoses patients are there in the database, and kind of like aggregation tools that shows the frequency. So I2P2 was just a tool that helps the physician build up a solid use cases based on the data that's being reflected in the data warehouse. And then the first thing that, as you mentioned, is the COVID hospital operational intelligence, where the what-if scenario is built to estimate and forecast multi-scenarios, where, for example, the number of patients being expected to arrive is this number, and how much resources is needed and how much is being available. So this is give the hospital a chance to be prepared ahead of time before the crisis comes. And the second one is, as I mentioned, we were using different classifiers to estimate the severity of COVID patients. So, for example, the length of stay, the number of supplies, the number of medications they are available versus predicted as well. Since I was mentioning that the patient is the most important piece of the whole story, we need to focus on putting all the technologies to really drive a valuable impact to the patient directly. So one of the projects that we wanted to do is having a 360 patient experience, where we analyze social medias, for example, on all the Twitter accounts that the hospital has in Jeddah, Medina, and Riyadh. And what we wanted to do is that every single complaints coming up to the account is being documented and being analyzed using sentiment analysis models. Not only that, but the hospital uses a third-party vendors, Prescriptive, and Prescriptive is a benchmark patient satisfaction methodologies, where the patients receive a survey after every single visit. They evaluate different kind of dimensions, for example, from the parking, waiting time, the staff courtesy, the ability to know the treatment plan, etc. So those dimensions are being analyzed. So we analyze the dimensions of the profile of the patients. Where are they coming from? Where do they live? How old are they, etc. And that patient profile is also integrated with the clinic profile. So, for example, how many patients the clinic receives on a daily basis, on what kind of services, etc. So the combining those two profiles to build up an AI models that predict how likely a new patient and or a patient that's never attended this clinic, how likely that they will be complaining about waiting time, knowing that, for example, they are coming up from a different city outside Riyadh, and also the ability to understand the treatment plan, etc. So after a couple of months of deploying these models, the satisfaction score went up by on average 9 to 12%, which is a huge improvement when it comes to patient satisfactions. And the dashboard that we built is we try to our best to make it very simple. It's not overwhelming, as Dr. Mohammed Midfa was saying. That's overwhelming staff and it's huge issues when it comes to using AI, because we wanted to empower the clinicians and the staff in general, rather than bringing a lot of bottlenecks again on their busy schedules. So what the dashboard shows is that it's iconic images of smiley faces, neutral faces, and angry faces, and those faces determine how likely that this patient who would be coming tomorrow to the clinic or next week, how likely they will be satisfied with the waiting time, how likely that they will be unhappy about knowing the right information about their treatment plan, etc. And this model is one of the models that not only has the predictive capability, but also the prescriptive capabilities, because what if I know that this patient is unhappy, what, as an example, what I need to do in order to mitigate that risk. So there is a prescriptive actions that the system recommends. So it recommends, for example, do not book this patient in the morning, because it's very likely that it will be coming up from a different location. Do not merge, for example, multiple appointments, for example, taking a CT scan with an appointment, because that will delay the visit to the hospital, etc. A couple of use cases, again, they are developed recently in hospitals. So although no-show is a kind of typical use cases that statisticians have been working hard to really empower the hospital to avoid those situations. But we wanted to derive something really different, where we wanted to utilize the artificial intelligence to estimate the probability that a certain patient is not going to likely be attending their appointments. So we analyze the patient profiles. We also analyze the satisfaction scores predicted by the other models. So this is what I meant by knowledge transfer. And we wanted to drive more knowledge about the patient, how we can quantify their attendance into quantifiable models. And using simple classification models, we were able to enhance over time, and this is results by reducing the no-show by 6%. This 6% has a huge impact on the organization. It saved them millions only in a few months, which is because it's a universal healthcare. In Saudi Arabia, it's a universal health. The government provide the healthcare for the citizens for free, and this is really an opportunity that's being missed of revenue to the hospital, but also an opportunity to put another patient in that appointment instead of the one who's very likely is giving us the service provider. In order to highlight another use cases, OR, for example, surgery team, they provide the orders to the schedule team. The schedule team have one goal, which is basically try to schedule the appointment to provide the best utilization of the OR rooms. Usually the OR team schedule process is basically completely based on statistics. They analyze the average and the mean of the previous procedures. They quantify the how much, for example, number of minutes that this procedure is needed based on the history that they see in their data. What we wanted to do at that time is that we wanted to leverage machine learning in order to estimate the number of minutes. So it's a regression model that's being built, which analyzes the profile of all the surgeons, the profile of all the patients, and also analyzes the combined list of procedures, modifiers, secondary procedures, the anesthesia type requested, who's going to be providing the anesthetology, who's the anesthetologist who provides anesthesia, and also the bed requested. And combining all that amount of data, bring up a huge collection of features that was rich enough to build up a regression models that can estimate the number of minutes that needed for every single surgery. What also we are working on as the next steps, a lot of those surgeries requires ICU bed, and unfortunately securing an ICU bed is very critical. A lot of surgeries being cancelled due to the unavailability of the ICU bed on the day of the surgery or on the morning of the surgery. So in order to avoid all of that, we're working on the ICU unit to estimate or to predict the length of stay for every single patient. And this will give us a more understanding of the probability that there will be a secure bed in ICU for a certain surgeries, and knowing that this surgery is very likely, or this patient is very likely would need a bed in ICU after the surgery. So in order to also shed some light on the computer vision used in healthcare, we do have two use cases that we have been working on. First one is X-ray normality, abnormality diagnoses, where we wanted to make sure that there is a clear prioritization pipeline of all the X-rays being taken, and also for the MRI, we're doing automated segmentation that helps the organ transplant, for example, department to calculate the volume of the kidney or the livers. We're also working with them into identifying other measurements other than the total volume, for example, the cortex volume calculation, in order to enhance the matching criteria between the donors and the patients. To also conclude, all of those AI model capabilities, we thought that they would not be really the right vision to implement them if they are saturated around the hospital. And we have a model here, a model there. What we decided to do is that we wanted to combine all of those AI capabilities into a command center, centralized command center. So the command center was recently opened, and as you can see, all the dashboards that the AI model are producing are actually monitored within the command and control team. The command and control, for example, check the OR utilization. They can interfere if the OR utilization dropped, or if the cancellation risk is high. They can also interfere if the no-show in some specific unit are higher than the others or higher than the benchmark that we have.
شكرا دكتور محمد. نشكر جميع المتحدثين على تقديمهم العروض الرائعة. أما الآن مع الحلقة النقاشية مع الأخوة المتحدثين، وستنضم إلينا المهندسة ليال آشي، باحث مشارك بمركز الطب التجديدي بمركز سمو الأميرة الجوهرة بنت إبراهيم الإبراهيم للطب الجزيئي وعلوم الموروثات والأمراض الوراثية. كما سينضم إلينا مرة أخرى دكتور مصطفى قربان في الحلقة النقاشية. Engineer Layal Ashi, Research Associate at the Generative Medicine Center at Princess Al Johera Center, is joining us in the panel discussion. And of course, Dr. Mustafa Qarban is joining us again to answer all of your questions. So if you have any questions, please post them in the Q&A box. We start with the first question with Dr. Mustafa. So Dr. Mustafa, in 2 minutes, can you tell us how AI is reshaping healthcare?
First of all, I would like to apologize for all about what's happening today. I enjoyed listening the speeches from all the speakers. It was very insightful. Again, we just want to say that the data is the future that they're going to shape or reshape the healthcare in the future. I used to have one slide. I'm not sure, Dalal, if I can share with you the slide that I was able, this morning I wasn't able to show it and present it. I think it's very important to show how important is the data and where are the source of the data. In the future, the data will be collected, as you see here. What all the presenters are going to speak about it this morning is the data that is going to be collected from different sources. And it's in the future, the very important thing, the IoT and things like wearing watches, wearable devices, that they're going to send the data to the hospital. I think this is going to be a very important, it's going to play a very important role in the future. So it will have all this emergency response, smart nurses, smart hospitals, and you see all of them going to have this kind of relation which is depending totally on the data. So the future will be, as we said, it's a much more focus on the patient side, but also as well as like what Dr. Mohammed said the last presentation, there will be a very good chance to apply in the operation of the hospital and improving the hospital operation.
Thank you very much, Doctor. I have a question for Engineer Layal. What are currently the most promising applications or trends of AI in healthcare?
Hi, everybody. First of all, I'd like to say thank you for having me, and it's an honor to be a part of this panel discussion. So to answer your question, first, I want to preface by saying I'm not a medical doctor, so I will be approaching this from more of a artificial intelligence perspective. So to begin with, I would like to say, of course, the development of deep learning models has been mentioned before, and training them on previously captured radiographic images. But I won't go into too much detail about that because Dr. Mohammed did a wonderful job with that already. For me, I think the most important part in improving medical imaging is to improve the tools that we use in artificial intelligence first. So there are two primary techniques that we are using currently, and one is pattern recognition and the other one is segmentation techniques. A good example of this is the use of convoluted neural networks to perform semantic segmentation. What semantic segmentation does is it associates a class to every single pixel in an image. So you can imagine this is massive amounts of pixels. So in addition to that, most CNNs have been using two-dimensional kernels, and we are currently now being able to use three-dimensional kernels, which means it gives the model full access to the 3D image of the 3D medical image, essentially. The problem with this is that it requires a huge amount of memory and also huge amounts of data sets, right? That being said, a more positive note is that Dr. Yogananda from the University of Texas has developed a pipeline only recently, maybe about a year ago, where it's a pipeline to detect gliomas, and his pipeline including pre-processing, takes only about 5 minutes. So there are huge strides being made already, and I think primarily this is because of the use of things like 3D kernels, and as well as something like semantic segmentation as well. So I think that's the direction that we're going to go with.
Thank you very much, Engineer Layal. I have a question for Dr. Mohammed Al-Midfa. So what is the impact of AI and radiology on the future of radiologists?
As I mentioned in my presentation earlier, the importance of AI and radiology is to augment physicians. So again, one of the applications that I mentioned was for an algorithm to specifically tell the physicians that, for example, in this study, you have an intracranial hemorrhage, please look at that quickly. This not only saves the time of the radiologist, but it also can save lives of patients. And in addition to that, some efforts are being made to sort of look at the patient data and decide what sort of study to go for. So for example, do we need to go for a CT with IV contrast, or do we need to go for a CT with oral contrast or without contrast, for example? So some efforts have been made to develop algorithms that can work that way. And that will also help in reducing the cost of acquiring these images and reducing the cost on and the burden on hospital systems. So that is also another important aspect, not only just to augment physicians, but also to reduce the cost and reduce the burden on the healthcare systems.
Thank you so much, Doctor. Now let's move to Dr. Mohammed Al-Hamid. We have a question for you. How are AI researchers in hospitals shaping up in KSA specifically and GCC in general?
I think it's an interesting question. So I think the key thing that we were focusing on is that we wanted to drive research, but also we want to have a clear pathway into making that research and applied. And I think this was the major strategies. That's how we can drive something that can be applied immediately. So having an immediate impact was the key success, at least for King Faisal, because we were focusing on things that has at the highest ROI. For example, it is feasible. The unit or the department really believe in what we are trying to do. They believe that this will save them, for example, cost, time, being more accurate in terms of utilization of time, etc. On the other side, for example, GCC, and I think this is really important, is that I think the momentum today when it comes to AI is bring a lot of opportunities, and there is a huge potential for collaboration and specifically on the data side. So research is all about having the right data, having the right quality of data as well, and combining the effort between hospitals. I think this would be a great to have for the coming few years, I believe.
Thank you, Doctor. I have one last question for all of you in 2 minutes. What are your thoughts on impacts of AI in future of healthcare? So let's start with Dr. Mustafa.
I think what we see, it's probably going to be applied very soon in the imaging, X-ray and X-ray diagnostic. It's been going on. We already used the AI for the predictive analysis for diabetic patients. I think it's already been used also in some other hospitals. We aim to build, as I said, a nationwide registry for diabetic patients. This is a very, I think within 1 year and 2 years, probably within 2 years frame, we will see the application of these two.
Thank you, Dr. Mustafa. Now with Engineer Layal, the same question, your thoughts and impacts of AI in the future of health.
I think there is going to be huge impact in terms of medical imaging, as everybody has said. And I think another one that people don't talk about enough is patient risk identification, because traditionally it's quite a linear way of thinking, and it's difficult to make these variables make sense, essentially. And machine learning and deep learning are better at non-linearity and thinking in that way. And I think that this is a huge part it's going to probably within the next, I think, 10 years, patient risk identification will definitely be massively improved.
Thank you, Engineer Layal. We move to Dr. Mohammed Al-Midfa. Same question.
I don't think I can add much, to be honest, to what has already been said by my colleagues. I see probably medical imaging is going to be the first thing to get such a huge boost in terms of applications of AI. And next, what Engineer Layal has mentioned is patient risk stratification is a really important also aspect of AI applications that we might see in the near future. So yeah, I don't really have anything more to add, to be honest.
Thank you so much, Dr. And finally, we move to Dr. Mohammed Al-Hamid.
I think the future is bright. I think the potential is already being proven. What I think will be really interesting to see in the next few years is the preventive healthcare, where we wanted to use AI to really prevent things from happening in the first place. Not on a big scale, but at least on a small scale, where, for example, readmission is a huge potential. We can predict readmission, but what exactly need to be prescribed in order to avoid that situation.
Thank you very much. الآن نترككم مع كلمة ختامية مع الدكتور جاسم حاجي، فليتفضل مشكورا.
Thank you, Engineer Dalal. I would like to again thank first all of you who attended and spent the last 2 hours or so with us. I would like to especially thank the moderator, the speakers, the panelists, our colleagues from the Kingdom of Saudi Arabia, from Dammam and Riyadh, mashkurin, from Bahrain, Dr. Mohammed Layal, and also Dr. Amna, who had to just leave early from Abu Dhabi. I would like to also thank especially my colleagues and the organizer here, Mr. Tushar Saho, the chairman of GC Media, who made all this possible. And in the background, of course, Vijay, who's been doing all this work. Nevertheless, for the patronage of Her Excellency, the Minister of Health, it's been very informative. We try to concise it, to get technically to all the areas of AI. We had the best to speak about it in the GCC. We're going to continue with other domains of AI. And the next we have 9th of October, AI in higher education with Excellency Dr. Sheikh Rana bint Isa bin Dahi Al Khalifa to talk about the universities and AI, and His Highness Sheikh Khalid in November, hopefully, about AI in sports. We will come back more on AI in health. I think this is just the beginning, and in Bahrain specifically, we have a lot of rising stars to focus on it, and in GCC, as we've seen with our colleagues, and they are very advanced in different hospitals or universities in such areas, and it shows the leadership's focus and attention on this area. Once again, I thank you all. I'm sorry we've taken a few minutes longer than we expected, and hope to see you again in the near future.
كل الشكر للدكتور جاسم حاجي. وفي الختام نشكر جميع الحضور والمشاركين على دعمهم ومشاركتهم الفاعلة. على أمل اللقاء بكم في ندوات أخرى بإذن الله، مع تمنياتنا للجميع بدوام الصحة والعافية. ودمتم في رعاية الله، والسلام عليكم ورحمة الله.